Well, hello, everyone. Thanks so much for joining us today for my little talk on the EKG cheat sheet, important changes that you don't want to miss. My name is Lindsay Tjiattas-Saleski. I am a family medicine and emergency medicine physician. I'm also the Associate Dean of Clinical Affairs at the Edward Via College of Osteopathic Medicine, Carolinas campus. I currently practice emergency medicine at a critical access hospital, as well as a larger academic facility in North and South Carolina. So I don't have any relevant financial relationships to disclose. And the objectives today are that we're going to recognize EKG changes that can lead to an appropriate clinical diagnostic decision, distinguish between emergent and non-emergent presentations, but honestly, we're going over mostly emergent presentations today, and contrast some of the findings between different EKGs. All right, so we are just going to jump right into it. So as you know, in the emergency department and in urgent cares, et cetera, you're handed a bunch of EKGs all the time, multiple times a day. And so one of the big things that we have to identify immediately is if something is a Stemi. So I know that all of you can look at this EKG and identify that this is an inferior wall Stemi. If you see, you have the ST elevation, mostly in leads 3 in AVF, a little bit in lead 2. Understand you only have to have about 1 millimeter of ST elevation there. And then the key on this is that you also have reciprocal changes in leads 1 and AVL, thus solidifying that this is in fact a Stemi and not another cause of ST elevation, other causes which we will go over in a short bit. As you know, a Stemi is complete occlusion of an artery. So this is full thickness transmural infarction, which is what's causing these EKG changes for us. So I wanted to start out with the worst, right? This is the one that we're all the most concerned about, really need to stay on top of, et cetera. So for our ST elevation MI, as we just said, it's a full thickness transmural infarction. And the general consensus is that in the precordial leads, so V1 through V6, we have to have a 2 millimeter ST segment elevation for men and 1.5 millimeters for women. And greater than 1 millimeter in 2 contiguous limb leads. And, remember that you're comparing that ST elevation to the TP segment here. So basically at the end of our T wave and the beginning of our P wave, that is our isoelectric point on the EKG. And so you are comparing this ST elevation that you're seeing here to that TP segment. So you can see the very obvious ST segment elevation. One of the important things when you're handed an EKG, especially one that maybe you're not 100% sure about or is a little bit of questionable, is that in especially a patient that is actively undergoing some type of infarction, that the EKG can change over time. So you need to repeat it. If it's questionable, if you're not 100% sure, hey, can you repeat an EKG in 5 minutes? Just have that going, 1 or 2 times so you can see what's going on and see if there's any evolution. All right. And again, we know that there's a lot of things that can cause ST elevation. We'll go over some other items after this, but you really do need to consider the worst thing first, right? That's kind of our job in the emergency department, in urgent cares, et cetera. Really, though, keep in mind that clinical picture. This is a clinical syndrome. You're going to have characteristic symptoms typically, although in women, we know these things can present in different ways. And this is going to eventually show evolution of elevation of our biomarkers as well. And remember in a STEMI that it's very important to look for those reciprocal changes because there are other items that will have ST elevation that may not actually show those reciprocal changes, thus cluing you in that it is in fact a STEMI. So other things that can cause that ST elevation, such as benign early repolarization, I want you to be aware here, we're comparing to the TP segment, right? So here's the end of our T wave coming into the beginning of our P, so the TP segment, this is our baseline. But the difference between benign early repolarization and STEMI is, number one, we talked about reciprocal changes, right? Benign early repolarization, there'll be diffuse ST elevation, but there will not be any reciprocal changes because there's not that actual damage being caused to the tissue, which is causing the electrical current conduction issues, right? And also we have the smiley face here. I love this picture. Credit to Life in the Fast Lane for this. But as you can see, we have this concavity or the smile to the ST elevation, also with that notched J point. Whereas if you compare here to the ST elevations, you can see what they do is they compare this to kind of more of a frown situation. Doesn't have that same smile, doesn't have that same concavity that this has. So as we said, the EKG evolves through, or can evolve, and it typically does evolve through a typical sequence if it is in fact going to be an ST elevation MI. So usually what will come first is you get a little bit of hyperacute T waves. They'll be wider than normal, they'll be tall, and then you develop the ST elevation of the J point, in knowing ST segment retains its concavity, and then the ST segment becomes more pronounced and definitely more convex. Just know that the ST segment may become indistinguishable from that T wave. It kind of all melds together. And then on improvement in reperfusion, you'll see the inverted T wave here. The ST elevation improves and there's some T wave inversion. And then of course you have normalization with a persistent Q wave due to that overall damage. So we've talked about ST elevation in a STEMI. Now I want you to take a look at this EKG. All right, so we're looking at this. I see in leads 2, AVF, V5, V6, V4, all of these, that there's a bit of ST elevation happening in multiple leads. One could even say just diffusely. And let's also say that this is a 30-year-old male who's presenting with sharp chest pain that is a little bit on the pleuritic side. It improves when he leans forward. And then, of course, we have the positive arrow signs on the EKG, right? That are showing that there is, in fact, ST elevation diffusely, except in AVR and V1, okay? And note that this problem that we see here on this EKG, which I'll show you on the next slide, but it goes through stages. So there can initially be ST segment elevation and also some PR depression, which I want you to see over here, okay? But do we see reciprocal changes on this EKG? I don't see any reciprocal changes. I don't see any inverted T waves, any ST depression anywhere. So that's interesting. And this PR depression in association with this diffuse ST elevation and sharp pleuritic chest pain in an otherwise healthy 30-year-old that improves with leaning forward, this is pericarditis, right? So pericarditis is... On the EKG, as we said, you'll see diffuse concave ST segment elevation and diffuse PR depressions. This does not have that tombstone pattern, right? It doesn't have that, frowny face pattern, which would be more typical of an ST elevation MI. And this is due to pericardial inflammation. Okay, and this can occur after an MI, which is interesting, and occur about even up to more than a week after an MI, but which would be the result of Dressler syndrome. I'm sure you've heard of that. But usually can be 2 to 3 days after the onset of an MI. And you may also hear a friction rub on exam. I would love a show of hands if we were live to see how many people have heard or can hear a pericardial friction rub, but this would be a classic finding. Again, improves with the patient sitting forward. And you do need to worry that this can progress to cardiac tamponade. Overall, the causes of this, it can be status post an MI that we were talking about. It can also be status post open heart surgery, but it can also be caused by a lot of other things, including of course, idiopathic, but also viral. I believe the most common is Coxsackie virus that causes that, amongst TB, lupus, uremia, etc. So knowing that this can be caused by so many different things, the main key is that it can be treated, it can be treated in various ways, and the treatment typically depends on the cause. Now, moving forward on to our next EKG, take a look at this one. So rate rhythm axis, we have a little bit of left axis deviation, but I'm going straight to the ST changes, okay? So I don't necessarily see any ST elevation in the limb leads or the precordial leads, but I do see some ST depression here in V2 and V3, okay? And I do see some flip Ts in 1 and AVL. And we'll point these out on this EKG here. It's the same one, but basically the things above the yellow line just show a little bit of that ST depression in leads V2 and V3. So it doesn't look horribly concerning, but there is something very specific that we do need to be concerned about with this EKG. If you see ST depression in leads V1, V2, V3, you should be checking posterior leads. Why? Because if you're checking the posterior leads, you are looking for ST elevation in leads V7, V8, and V9. These leads are placed on the back because ST depression in V1 through V3 can be a sign of a posterior wall acute MI. So this can be 15 to 20% of STEMIs, and they're easily missed because there's no ST elevation. The clinical significance of a posterior wall MI is that these folks are having a posterior infarction that usually accompanies 15 to 20% of STEMIs. It's an extension of another STEMI that is going on, usually in the context of an inferior or lateral infarction. You can, however, have an isolated posterior MI, but this is less common, usually only about 3 to 11% of the time. So again, you have that posterior extension of the inferior lateral infarct, and it implies that there's a rather large area of myocardial damage with an increased risk of left ventricular dysfunction and potentially death. So that's why this is so important to look and make sure that if there's ST depression in leads V1 to V3, that then you then do a confirmatory EKG in the posterior aspect, which I'll show you how to place those leads in one sec, with V7 to V9 to look for ST elevation. Now, as you can see here, this is one of my fellow co-workers who was a gracious participant in this. We have our normal lead placement here on the anterior wall, but these are leads V7, V8, and V9. V7 is the left posterior axillary line in the same horizontal plane as V6 typically. And then the tip of V8 is the tip of the left scapula in the same horizontal plane as V6. And then V9 is the left paraspinal region, again, in the same horizontal plane as V6. And one of the key things with this is the degree of ST elevation seen in V7 to V9 is not as exaggerated usually as an anterior, as the anterior leads would provide. So it's typically modest. So you need to note that even just like 0.5 millimeters of ST elevation may be enough to make the diagnosis of a posterior STEMI. So something to look out for there, folks. All right, so now take a look at this EKG. What are you looking at here? This is one that we probably see all the time in the family medicine office. We see this very often in the ER, but the key with this EKG is the clinical presentation. Is this patient presenting with new onset chest pain, or are they there for maybe a little bit of lightheadedness or something else where you're just checking kind of a screening EKG on them? Well, as you all know, this is a left bundle branch block. Sure does have some ST elevation going on, right, which can be concerning, but there's a reason why we bring this up. It's because the left bundle branch block, specifically a new onset left bundle branch block, in the clinical presentation of clutching chest pain, diaphoresis, all of the things that would go associated with a patient presenting with the right clinical picture can be a STEMI equivalent. Okay, so a new onset left bundle branch block in the setting of a typical MI is considered a STEMI, and you would need to emergently discuss with your cardiologist. And here we have the criteria for a left bundle branch block. Just know that in V1, you have the QS or the RS complex, which is rather large, and then you have those, essentially those bunny ears in lead V6. The big important thing about this is you want the appropriate discordance, because what if you have a patient that has a confirmed previous left bundle branch block, right? But they're complaining of that. It's not new, and they're complaining of the chest discomfort and they're the right clinical picture. Well, that is when you apply the Scarbosa's criteria. Okay, so within this criteria, there's 3 criteria that are used to diagnose infarction in patients with an existing left bundle branch block. And the important things here, discordance is good. Okay, I'm just going to say that. If you have your QRS complex here, like you see in figure A with the flip T wave, that is discordant. Okay, discordant is good. Or if you have your S complex here with the appropriately correct T wave here, that is again discordant, and that is fine. However, concordance is bad. Okay, so we can have in the Sgarbosa's criteria, if you have concordant ST elevation, like you can see here, where you have 1 millimeter in leads with a positive QRS complex, so positive QRS complex with over 1 millimeter of ST elevation, okay, the Sgarbosa's criteria is on a point system, and you get a certain amount of points for that, which would apply to the patient potentially having a STEMI. Concordance is also bad in the opposite direction, okay? We have the large complex here, okay, but this shows concordant ST depression of greater than 1 millimeter and leads V1 through V3. So here's your ST depression in association with, this is concordant, okay? So both are below the line here, and that's bad. And then the third criteria would be excessively discordant ST elevation. Okay, so basically there was an original rule which showed that greater than 5 millimeters of excessive ST elevation, discordant, right? The complexes are discordant, but excessive ST elevation. But now they just say that it's a STEMI if there's discordant ST elevation with an amplitude of greater than 25% of the depth of the preceding S wave. So we have our S wave, and if this ST elevation is greater than 25% of the depth of this S wave, that is positive in our Sgarbosa's criteria. So just to recap real quick on that, if it's chest pain with a new onset left bundle branch block, that is concerning for an ST elevation MI. If it's an existing left bundle branch block, what you'll do is you utilize the Sgarbosa's criteria to appropriately diagnose the patient. All right, so moving on, looks like here we have some more ST elevation, don't we? We can at least tell that those T waves are definitely not looking normal. Look in leads V2, V3, V4. And then, of course, we have the positive arrow sign, right? The V4, V5. Okay, you can see that there are definite peaked T waves here. These are tall, they're prominent, symmetric T waves in the precordial leads. And maybe you notice here that there's a little bit of an upsloping here. Okay, the upsloping is a little bit different. And then you possibly have a little ST depression when compared to that TP segment. Okay, does anyone know what this is? Very good. It's De Winter's T waves. So this is due to a proximal LAD occlusion. This can occur sometimes about 2% of patients. But the diagnostic criteria for De Winter's T waves are tall, peaked, symmetric T waves in the precordial leads, usually with that upsloping ST segment depression of greater than 1 millimeter at the J point, and then an absence of ST elevation in the precordial leads. There's no ST elevation, just like on our previous EKG, no ST elevation here. Okay, so this is, I'll allude to this as almost a STEMI. This is very concerning to me, and you would definitely need to have a discussion with your cardiologist regarding this, because STEMI morphology may come before or after this De Winter pattern. So this is an emergency, and you'd want to talk to the cardiologist about this. The one other thing I do want you to consider with this, of course, is hyperkalemia, because we know with hyperkalemia, you can also have very peaked T waves. So this is why, as always, the clinical picture is important, but this is a very concerning pattern. Our next EKG shows, let's see here, I see some ST depression in the inferior leads. I see some ST depression in the lateral leads, starting in V3 though, but also V5 and V6, and some ST elevation in AVR and V1. It's subtle, but it's there. The ST depression is not subtle, but the ST elevation in V1 is subtle, AVR is definitely there. So when you have ST elevation, AVR, and V1, and diffuse ST depression otherwise, does anyone know what this is? It is exactly what we said it is. ST elevation and AVR with diffuse ST depression. These are typical ECG findings for left main coronary artery occlusion. So again, widespread ST depression in the most prominent leads, 1, 2, and then V4 and V6, ST elevation in AVR, and potentially V1 as well. And then the magnitude. So what's really concerning about this is that the ST elevation in AVR is correlated with the mortality in patients, as you can see those numbers here. But you do want to consider the presentation here because other things can cause diffuse ST depression, right? You don't want to just see this pattern and necessarily pull the trigger. Something else could be causing these global changes. Is the patient anemic? Are they in shock? Or is this a 50-year-old gentleman presenting with chest discomfort that is severe? They're diaphoretic. So again, you really do need to consider the entire clinical picture for this. But this is something very important to watch out for. All right. So now, what are we looking at here? Oh, I see what we're looking at. Okay, so it's almost, I'm looking at our ST changes here. I mean, I see a little bit of T wave flattening, nothing really major going on, but I do see this odd pattern here in V1 and V2. It almost has the appearance of a right bundle branch block and way. There's some widening in general of this. Here's just a little bit of a closer picture to this. And if I said that this was a patient, a 50-year-old patient presenting with chest discomfort, or maybe not presenting with chest discomfort, but look at it again. This is Brugada. So Brugada, the EKG findings are essentially like that right bundle branch block type pattern, but there's this ST elevation associated with it, especially in leads V1 to V3. And there's two types of Brugada. There's type 1 and type 2. The type 1 ECG pattern is commonly known as the coved type. That's where you have that ST elevation, the coved ST segment elevation. And then the type 2 Brugada has this kind of saddleback appearance to it. So I don't want to dwell on it too much, but it is something that is important to watch out for, this Brugada syndrome per se, because this is an inherited mutation in sodium channel, and these guys have a 10% risk of mortality yearly if undiagnosed. So they may not necessarily present in chest discomfort. This can have more of a, you could just be screening them for something else, but they don't necessarily have any underlying disease. There's no structural abnormalities. It's just due to sodium channels, they have a predisposition to malignant ventricular dysrhythmias. So here are the clinical criteria associated with this, something to watch out for when you are screening people, et cetera, for EKGs. And now I think this is another kind of obvious EKG where you can see that there is some, there are T-wave inversions, a lot V1 through V6 here, also in the 1 and AVL, so kind of a little bit of a lateral extension here, but deep inverted T waves. I think we can all agree that this is a scary looking EKG. However, if I told you this is a 50-year-old male with history of exertional angina, but he's not presenting with any pain at this time, okay? So you're doing this EKG as a screening, et cetera, and it's coming up to look like this, and he is not having any discomfort whatsoever. And then again, we have the positive arrow sign on the EKG, right? Showing us that there are, yes, we are in fact to be clued into these deep T-wave inversions in the precordial leads here. And these are known as Wellens waves. Okay, so there's Wellens syndrome. There's two types. There's type A, which is only 25% of the cases, which has these biphasic T waves over here. And I mean, how many times have we all seen biphasic T waves on an EKG, right? I mean, multiple times. But if you see them in that V1 through V3 area, and especially in a patient that is not having any current chest discomfort, this is something that you need to consider. And then also type B, which is 75% of the cases, which has those deep symmetric T waves that you need to be worried about. Wellens waves are concerning because they are due to a critical stenosis of the left anterior descending artery. So there's a super high risk for an anterior wall MI. And like we said, you want to consider Wellens if you see those inverted or biphasic T waves in V2 and V2 through 3, and these may extend to V1 through 6, but also you can have them in the lateral leads 1 and AVL. But again, the key with this is about the clinical history, right? That the EKG pattern is in a patient without pain. So you may actually have minimal or no biomarker elevation, but this is something that definitely needs to be pursued and discussed with a cardiologist. that is all I have for you today. I just wanted to clue you into a few really some wonderful references, but mainly Life in the Fast Lane. If you have questions about anything in particular, this is a great website. I use some of their images today in the presentation. They have wonderful explanations of EKGs that are very simple, I think, and good to go through. And I look forward to talking to you again soon. Thanks so much.